changes, and I talked about memories, and that these are maladaptive. They can be maladaptive. But all of these other psychological manipulations, are they modifying the plasticity? I don't think so. I think what they're doing, the plasticity has occurred, the information is getting to the brain, and what you're trying to do is alter the cortical representation. You're actually dealing with the pain side of the problem rather than the processing side. And there's a big difference. And I think that many alternative approaches are effective because they're all operating at that level, all right? Like acupuncture, biofeedback, and a variety of other things. I don't mean to be demeaning. Placebos work. Look, here's an example. Sir, you're my patient, all right? Now, just to prove to you about placebo, I think you'll believe it. Now, you come in, you have a pain problem. I've been treating you for 6 months. And so, look, we're having trouble. And I said, look, sir, I want you to try this new pill. I just spoke to, well, to be really honest, I don't think it's going to work. You know, I've given it to 10 of my patients and nothing. But look, I got nothing for you. But, you know, you never know. You could get lucky. The guy from the big pharma, he told me it's great. So here, give it a try. All right, that's scenario number one. Same pill. Same pill. I come in. Sir, look, I'm really excited about this. This is a new drug. I've tried it in several patients, and things look really good. We're getting good results. The data from other studies is really, I'm really optimistic. I think it's worth trying. Try it. Take it a few times. It may not work right away, but I'm really optimistic. Okay. What's the better approach? I mean, duh. Same pill. If it's all about pharmacology, binding, it shouldn't make a difference. The first I added, the second one I added a placebo. Every drug, if the physician administers it right, has a placebo component to it. You have to believe it's going to work. The other thing is actually called the nocebo. Literally, I can make a drug that is known to work worse by giving you lousy information, bad information. The brain really influences. I don't know what, if Marika, who teaches pharmacology, wants to throw a dart at me, but I really believe that absolutely. Okay? Yes, ma'am. Okay, without question, people with chronic pain will have depression. Be very unlikely not to. Okay, so if you were to treat them with psychoactive drugs, antidepressants, at antidepressant doses, it's a good idea if they're depressed. All right? You have to face the day. You got a pain problem, deal with the depression, it's a good idea. I don't believe that if you're depressed, you're more likely to become a chronic pain patient. I don't know if there's that good evidence. Now, one other important thing. For neuropathic pain, not for the tissue injury pain, neuropathic pain, there is very good controlled trial evidence that some of the antidepressants, independent of their effect on depression, in fact, at doses that are not even antidepressant, can be effective for neuropathic pain, postherpetic neuralgia and diabetic neuropathy. And the drugs I'm talking about are the old antidepressants, the sort of we call dirty ones, the so-called tricyclics like Elavil, all right? If you can tolerate the side effects, it can be very effective in some patients. Or the very newer ones like Cymbalta, duloxetine, venlafaxine. These are mixed, what we call serotonin norepinephrine. It turns out, interestingly, the pure serotonin uptake inhibitors, the SSRIs, like Prozac, don't work. They work for depression. They don't do anything for neuropathic pain. We can talk in some other time about mechanisms. But so the antidepressants at doses that are not even antidepressants, if you use the right ones, can be remarkably effective in some patients. You can't predict ahead of time for neuropathic pain. But unfortunately, there are plenty of people who still have trouble. Local anesthetic patches can be effective for patients with postherpetic neuralgia. You block the input right at the level here. Ideally, we're going to eventually come up with a local anesthetic that you can pop a pill that mimics what those kids in Pakistan have, because we now know the exact mutation that causes that, and what turns out to be exciting. So local anesthetics work on sodium channels. They affect ion flow. They affect conduction of impulses. The typical local anesthetic is what? Like lidocaine, Novocaine, that the dentist uses. Well, that works beautifully. That's why the dentist can work on your mouth. But if you get it systemically, you can have cardiotoxicity, brain toxicity, because that's a non-selective blocker